All right, we'll get going. First of all, approval of the minutes from November 21st. That was not here. So I'll entertain a motion.
There's a story that goes with that.
Make a motion.
All right, motion.
All right. All those in favor say aye. Aye, can we approve those? New business. Go ahead, Phil.
Yeah, we have, this is an interesting situation. The captain from the Andes squad advised me that Dr. Peter Sosnow has been asked by them to be their service medical director. And he reviewed the role and responsibilities document approved by the REMAC and said he couldn't sign it for liability reasons because it holds the service medical director, quote, directly responsible, close quote, for medical care provided by the agency. Now, the DOH policy statement on medical control speaks of indirect medical control. So what I did was I sent to all the REMAC members a copy of the role and responsibilities document and also the DOH policy on providing medical direction. I told the captain at Andes to tell Dr. Sosnow that we would be discussing this at the REMAC meeting, but Dr. Sosnow is also the medical director for Delhi, and he's already signed one of these documents. So why he's finding the problem right now, I don't quite understand. And I said that to the captain. And I said, you know, he passed it on to the doctor for me, but I said we will take a look at it. Anyway, the role and responsibilities document does say that the agency medical director is directly responsible for the medical care provided by the certified personnel for that EMS service. And he says it's Dr. Sosnow's his point that it should say indirectly responsible. So there we have it. That's the issue precisely.
Well, the thing that we signed as service medical director is drafted by the Department of Health, right?
The role and responsibilities item that we signed, that the service medical director signed, is drafted by this REMAC. Really, it was established by this REMAC some
so it's not a statewide agreement.
It's not a statewide. No, not at all. No, it's unique to this region.
So you're suggesting that we revise it?
Yeah. Well, whatever. This is the first time we've ever had an issue with the doctor saying I can't sign it for liability reasons because it holds me directly responsible. Everybody else has always signed it up to now, including Dr. Sosnow himself.
All right. Any discussion?
It's probably safe to have an indirect.
Change the direct to indirect.
My suggestion, for what it's worth, and I throw it down on the floor, would be to change the word direct to indirect as per, and put in as per the requirements of DOH policy statement number 11-03.
Phil, read that blurb from the DOH thing. It says indirect medical control.
Yeah, it's as I said,
maybe we should insert whatever that exact phrase is, if that's what the DOH specified for the service medical director.
Yeah, okay, the responsibilities of the service medical director. There are 8 bullet points that said, unless otherwise provided in statute, rule, or policy, the responsibilities of an EMS service medical director shall include but not be limited to assurance that service certified EMS personnel are oriented to the protocols promulgated by the CMAC and the REMAC for the areas of operation of service, interact with REMAC in the development of protocols, regional QI, and disciplinary issues, active development, review, and participation in the QI program, working with the service providers on issues and questions regarding all ages of patient care, participate and interact in other activities that relate to the provision of medical care or effective patient care provided by the EMS service, participate as necessary with the service's certified EMS personnel in continuing education programs and the recertification process, verify by affirmation provided by the department that he or she serves as the medical director for the EMS service. That's the document where the agency gets recertified every 2 years. Providing medical oversight inclusive of the levels of care and/or BLS adjunct treatment protocol specified, and in accordance with New York State law, regulation, or department policy, submit any documentation required for additional level of care approvals obtained by the EMS agency represented. And then it goes on to say, Article 30, Section 3013-5 of the Public Health Law notes that notwithstanding any inconsistent provision of any general, special, or local law, any physician who voluntarily and without the expectation of monetary compensation provides indirect medical control, there's the word indirect, shall not be liable for damages for injuries or death alleged to have been sustained by any person as a result of such medical direction, unless it is established that such injuries or death were caused by gross negligence on the part of such physician. So that's the immunity from liability, that's the little escape paragraph right there.
Right.
And that's precisely, I think, I didn't speak with Dr. Sazna directly, but I think that that's what he's looking to have in the document that he signed.
Okay, so the simplest modification we could make would be to change direct to indirect.
Right. And in accordance with policy, state.
I mean, we could just adopt the policy number whatever and use that for the role of the medical director too, directly from the state, if you wanted to do it that way.
Some of it should be probably spelled out. We could just, we could just take the bullet points I just read, plus the immunity from liability section, and put that right into our role and responsibilities document.
And take the direct out.
Would it be rather to simplify it?
Yeah.
Rather than
Importance of our health, right?
Well, if I can make Dr. Shaz, I'm happy.
That certainly will make Andy's happy.
Yeah,
If he's happy, they're going to be happy.
I think the simplest thing would be to change it to indirect, and then it's one step removed.
Yeah, okay.
Here.
We can have some kind of reference back to this policy statement.
Right, that'd be good.
Okay.
All right, so revised service medical agreement. Current REMAC policy regarding cardiacism.
I'm sorry.
Around the second bullet,
Oh, yeah.
cardiacism.
Yeah, now, Howard brought this up at our last REMAC meeting, Howard Hughes, about the cardizem. So a number of agencies are not carrying cardizem. The reason that the agencies are not carrying cardizem is because I don't have a copy of it here. The REMAC passed a policy back in 2008, I believe it was, that the reconstitutable cardizem should not be carried on our agencies as part of our agency's formulary. So I'm bringing it up simply because Howard brought it up at our last REMAC, and I didn't have chapter and verse on that policy statement of our REMAC at that time. In the meantime, I looked it up and I sent everybody a copy of it by email. So there it is. This was August 13th, 2007. This was from the June REMAC. At the last meeting of the Regional Medical Advisory Committee, that would be June of 2007, there was discussion on the subject of the continued availability of diltiazem. Dr. Leinhardt advised that the reconstitutable version is not to be used in the pre-hospital sector, since the State Medical Advisory Committee has so directed. The packaging of the drug that does not have to be refrigerated is no longer being manufactured. When you no longer have a properly dated supply of it, a beta blocker or amiodarone can be used. However, medical control must be contacted in each instance when the current properly dated packaging of diltiazem is no longer available. It was noted that some agencies still have a properly dated supply of the drug on hand. Therefore, please advise, this is the memo to all the ALS agencies in our region, please advise all active duty techs serving with your agency that online medical control must be contacted for patients meeting the ARIMS protocol clinical presentation for diltiazem once a properly dated supply of diltiazem is no longer available, so that a substitute medication can be ordered. There is no standing order for substitute medication at this time. That was the policy that the REMAC developed in 2007.
And that was when we were beginning to experience shortages, sounds like. When the state put the grid out, we had all these alternate drugs for the drug of choice, and then you could substitute this, and you could substitute that, and we developed that grid. What did we say about, was diltiazem in that?
I don't know that diltiazem was on that grid, because that's the one that had to do with... I don't know. That's a very good question. Howard, do you have any recollection of that? state came out with the substitute meds list?
I do not.
And I didn't bring my notes, so.
Okay.
It's on the website. It's a CMAC advisory, or policy advisory statement.
Okay, I can find it in a second.
Should be 1301 or 12.
Give me a second.
It says, key points in the neurocomplex tachycardia says, if diltiazem is not available, contact a physician for medication choice.
All right.
So,
But I would think that with the shortages going around, you don't want to go nuts about dealing with this in a meeting every time one comes up, though.
Right.
We're going to continually have stuff.
That's not going to be an issue, I don't think, because during state council, we did have a collaborative protocol meeting on a sidebar after to get all of the regional councils together. And one of the things, and I think Gus brought it up, is having a freestanding formulary for alternative meds, so that exactly the point, it doesn't have to come up, and it'll be, throughout, from Westchester basically to Canada.
Yeah.
So that was one of the suggestions that did come up, is have a freestanding formulary for alternative meds.
Let the record reflect Dr. Markowitz has arrived.
Sorry, meetings this morning.
The policy that Mary referred to does not have an alternative for
Correct.
There's no other.
Has
No.
no other.
So I guess so we're not, so if you don't have it and you call medical control, it becomes their issue about what you're going to do about it. whatever the rule
okay,
is.
so you're just reaffirming your policy
So
statement?
nothing's really needs to be changed. And we don't have a substitution.
Why was it we couldn't use the reconstituted one? I realize the vial's 100 milligrams. Medication.
Probably. I mean, it's a big issue, if you have different formulations being supplied by hospitals and EMS is being asked to, read the labels closely because this could be 10 times what you think it is. They're trying to eliminate that possibility of medication errors. So there was discussion about that as well, about, if we're pharmacy dependent on what they supply us and they give us what they got, but it isn't what's in our protocol, they're kind of asking for trouble, and it puts a lot of burden on the provider in the back of the moving ambulance to decide for BART ambulance what the concentration is and should be and what the drip rate is now. So there is a desire, at least, to standardize that, to make it explicit in the protocol about what concentration we're talking about. But it's a challenge because pharmacies, the hospital pharmacies go in and out of supplies. But I think we'll jump a little bit to the collaborative protocol meeting that we had Tuesday. So the collaborative protocols, which started out with Barron's and Mountain Lakes and Remo's, now encompasses 6 regions, and will soon encompass Monroe Livingston. So the protocols are basically on ice until January of 2015, which is when the new protocols, I think, it's hoped to, the revisions will be held until January of 2015. The A&P has to be addressed. It's a new category of provider. And they're deferring that introduction until these protocols until January. They have DOH approval to defer it till then. We did discuss, this perennial drug shortage issue. Do you have to go back to the drawing board every time some drug becomes unavailable? So one of the suggestions was, if we're going to introduce a drug into the protocol, what's its alternate? And if Haldol is reintroduced, for example, for excited delirium, add droperidol as an alternative, so that the protocols will come with preloaded with alternates to these drugs. If you're out of midazolam, can you use Valium? That kind of discussion. So it'd probably save us from having to deal with the alternative So it's pretty interesting to see the participation across the state. And the group decided, should we promulgate this as a statewide protocol and push the other regions to join us? And it was really decided to just keep it the way it is, and if regions want to join, they can. But there's now 6 regions, including Westchester. Soon we'll include the 7th region, Monroe Livingston. There's a pretty big, and Monroe Livingston is unique because they have University of Rochester. Pretty big EMS research arm there. They've done some interesting things there in the EMS research realm. So the protocols, now are overlaid by this much larger participation from academic medical centers. They're starting to ask questions such as, when they got to pressors, there was a general consensus that dopamine should probably go. And then we immediately got into discussion about substitutions, but even before that we got into discussion about, should we have any pressor? Just eliminate all pressors. How often do we use dopamine? And I bring that back to this group actually. Can we find that out in our own region, contribute that to the collaborative protocols? Because there is, Monroe Livingston is like EPCR and very closely held, and it's a city, and they can do a lot of analysis within their own database, and they have their own sort of closed world of data. Can we answer a question like that? Like how often in our region?
We'd have to kind of poll the larger agencies just to get a feel for it. I think the larger agencies might be able to give us an answer.
Well, it's interesting. If you say larger agencies, you're talking generally urban, although CMT not necessarily.
Well, I know larger agencies in our region, the 3 of them would be Fulton County Ambulance, GAVAC, and Oneonta.
A lot of things are inferred on the rural regions of the state. So when they come up with the need for a pressor, they say, well, they probably need it in the rural areas. So let's find out. I mean, how often do we use it?
I can tell you it's probably been longer than 3 years that dopamine's been used in Hamilton County and in the agencies.
I can tell you, we just discussed this in my agency a couple of months ago, and went back to the PCRs. We haven't used dopamine from my agency in 15 years. We have not used it.
The other question that came up, I think a couple of questions that came out of that discussion in particular, is how many agencies have had the opportunity to use it and just have it, whether it's dopamine, whether it's an epidrip used, as a pressor, or not. And one of the questions that Dr. Daly had brought forward that I think he wanted input on is, look at your last 10, obviously some agencies may not have that, but look at your last 10 cardiac arrest reversals as one thing. And what was the last blood pressure before you turn that patient over to the hospital? So, are people afraid to hang dopamine? Are they afraid to hang epi? Were the indications there and they just didn't do it? There was a lot of discussion on that. So, he did ask to bring that back, and that would probably be a Joyce thing, to get some survey out on the last, your last number of cardiac arrest reversals, in which it would be based off of the protocol. What was the last blood pressure before you turn that patient over to the hospital?
All right. So Joyce, before we go too far down this road, how easy is it for us to pull within our region, either back from the state? The state is still, key punching 2007. Right?
Back from the state, forget it.
All right, so we have to do it on our own. So do we have enough PCRs or other paper to do a study that says, okay, well, let's look at all cardiac arrest. How many of them had return to spontaneous circulation?
We have no.
How many had a blood pressure?
Well, ePCRs, we'd have to, I don't know if that data point would be available on all the PCRs.
All you have to do is request it. I can tell you how many cardiac arrests we've done, and certainly we can, look and see what the last blood pressure was for the last 10 reversals.
I can look at cardiac arrests from now on of the small agencies, but again, they're tiny agencies, and you're not going to get much as far as data as far as cardiac arrest reversals.
So maybe, Joyce, what we could, whatever's easy to get, I mean, basically, even in Monroe, Livingston, they just said, let's, nobody has 100% access to real data. So just a sort of curiosity about return to spontaneous circulation was, can we do a convenience sample? Like, what data is readily available and what does it say?
Well, I will ask the larger agencies that are using EPCRs, how easy would it be if I asked you, say for the last 6 months, to get that information? Would it be possible?
The question, we asked that very question as far as whether they wanted a time frame or not, and Dr. Daly was pretty specific in the last arrest reversals as opposed to the time frame, because at 6 months and 1 day you may have had your only reversal. So not everybody's going to have 10 cardiac arrest reversals. Maybe they're only going to report 2 or 3.
Okay.
So Joyce, I think the data.
How far back do you want to go? I mean, you have to go.
Well, I mean, for us, I can go back to 2007, but I don't know if I wouldn't have to go back that far.
So I think what we could supply maybe to the effort of the collaborative protocol to kind of get at this issue, like should there be any pressure on board, is if you ask EPCR agencies, how many cardiac arrests have you had? That's the big universe. Of those, how many had return of spontaneous circulation? And of those, what was their last blood pressure? So it's just 3 questions. How many cardiac arrests? How many had return of spontaneous circulation? And of those, what was their last blood pressure recorded? So the sentiment being that if you have return of spontaneous circulation associated with a low, below 80 blood pressure, those patients should be getting something.
How far back do you want to go?
How far back you want to go, Doug?
No, let's just look at 2013 if we have it.
Oh, okay. All right. That would be an easy figure, relatively easy figure from us.
We know that we're not describing the whole region, we're just describing the available data. We'll know where it came from, right? So. And then we should sort of put that into the collaborative effort. So it's kind of interesting because the collaborative protocols group is finally moving off of protocol writing in a vacuum with no data and asking questions like, how often do we use dopamine? Why do we have presence? Right? So it's kind of interesting. So it's finally the feedback loop might be created, and there are large segments of the state that have EPCR, so and they're all different. But if we can pull it, that would be useful.
Okay. How easy would that be, Beth, for you?
I can only give you data from October 15th on, because I only went to electronic PCR October 15th.
I'm talking about, I mean, if you could.
Oh, I can pull it easily.
Okay.
I get a report every week of ROSC.
That information.
So all I would have to do is find out how many overall cardiac arrests I can. I can search them by primary impression of the providers. So I can.
What is the national experience with ROSC? It's like less than, it's like 5%. I think in urban areas, like Seattle, Pittsburgh, it's like 5%.
Well, and there's 2 new huge studies out that ROSC may be detrimental. Well, one that ROSC may be detrimental, and the other one is from the New England Journal of Medicine, and one's for the Journal of American Medical Association, JAMA. One says that ROSC may be detrimental in that it causes more.
You're talking about cooling.
Cooling efforts, thank you.
Right. The alternative to ROSC isn't so great.
Yeah, right, I was going to say.
Sorry, brain is not at 100%. But
it's very stable, though.
Yeah.
It's stable.
Yeah, there's some questioning about the cooling with ROSC, the hypothermia with it. So, Melrems has pulled their whole therapeutic hypothermia protocol.
Which is interesting. It's kind of a knee-jerk reaction since Dr. Freese is doing good research in New York City, which indicates that intracardiac arrest cooling may be very beneficial. So I wouldn't throw your ice coolers out yet.
So.
It's a matter of degree, right?
And then there was the matter of degree. How cold is cold
Right.
enough? Is 34 or 36 degrees Celsius adequate? And we joked that in this section of the world for half the year, but they're colder than that,
Right, we're pretty cool out here.
Just drive with the windows down.
So, I mean, there's been discussion around that, but yeah, I can pull the data, but I can only pull it from October to,
So Gavac, you can get it. Fulton County, you said you have it. And the only one I have to ask then is Oneonta.
but,
Of the
Certainly
four
Well, you
people.
should ask
would be
LifeNet
in
as
favor
well,
of getting rid of all
because-
of our pressers, maybe getting rid of dopamine, but,
Is there an alternate?
I mean,
I have nothing to do with
we
it, so it works for me.
have definitely,
It's easy for us.
well, we haven't hung dopamine very often in the last 5 years. We have, I bet you last year alone, we hung an EpiDrip at least 5 times.
That's interesting. It harkens to a conversation that was had at the REMAC Academic Committee where we all agreed that paramedics are universally allergic to math. And that the idea of having to figure out things based on weight just scared them. But the idea of setting up a standard drip was not so scary. There's talk about going to epinephrine because it's just a mics per minute kind of deal.
And can you bolus it as well to simulate the drip and you can just keep doing it?
You could, and that was certainly a discussion, but you could also, you know, if you're gonna go to a bolus medication, maybe.
Push pressures.
Maybe
Yeah.
vasopressin,
Yeah.
you know, would be a better choice.
Yeah, Dr. Weingart's going to open up a lot of territory on that in emergency medicine. Push
So
pressures.
that's kind of out there, but it's interesting to see the questions that are being asked once you start engaging large academic medical centers. Rochester is the home, I learned yesterday, of Dr. Molst, you know, so the Molst form, it's not a real name.
Bamba, yeah, Bamba.
Yeah, she really attacked me yesterday.
You haven't learned how to hide from
I
her?
was in the wrong room. I was looking for a meeting. I opened the door. It's like this big palliative thing going on. And I was like, oh, maybe you want to stick around. I said, and I just kind of like got out of there because I was looking for the real meeting. And she thought I rolled my eyes. Her name was mentioned. Her Wolf was mentioned. And she came flying out of the room. I am Dr. Wolf. What? You rolled your eyes? Like, I did. I was looking for another meeting. I was like, but then it turns out that it's Dr. Cushman, who's the EMS/CMAC guy from Rochester, is promulgating these termination of life and palliative care protocols, which she claimed she's the mastermind and he's at her command. So, and I said, well, you know, we're very interested because we are going to explore those protocols in our own region, with collaborative protocols. So we'll be seeing what comes out of that. But she asserted that emergency medicine has, you know, a big role to play in those kinds of decisions. Seems a little late if you're rolling by ambulance, but in the interface getting pushed out to EMS to the point where you make a decision in a home and then leave. Doesn't sit too well with some family members, perhaps. So there's a lot of, you know, quirks to what it is that we'll be asked to do, and you know, how do you value any healthcare proxy decision form, even if it's not a MOLS form? What else would you honor or should you honor, right, as medical control? That was an interesting discussion. So Rochester is going to be in the fold. That'll be interesting. I thought I'd just take a break from the agenda here. Tom, we got into a discussion of excited delirium based on Gavak's experience this past summer. I thought it was an interesting discussion that is actually resulting probably in some formulary changes for the protocol. So Tom, you sort of describe your experience.
Dr. Daly had me bring up the episodes of Camp Bisco, and ironically, after the last REMAC meeting, Dr. Daly had sent an email based off of the conversation that Gary had brought up about getting some form of antipsychotic back in the formulary, and altering that formulary a little bit. There are some new drugs that are going to probably come into this, ketamine being one of them. However, regional councils are probably going to have pretty tight restrictions. We learned from, I think, Rochester, Dr. Cushman brought that up, that they only allow their MFI medics to use ketamine. That was one of the things. So we still argued the point that there needed to be an alternative because there's very few agencies that are doing that. So there was quite a lengthy conversation on which drug of choice, whether it be Haldol, Druperenol, I think there was a third one. that Dr. Daly had brought up, and basically all of which have black box warnings. So which is the lesser of the evil? And I think that it was pretty much decided that it is probably going to be Haldol, because that's what everybody is familiar with. So Haldol will probably be coming back into that excited delirium protocol for, it's certainly helpful. We learned at Camp Bisco, we were given 5 of Valium, 5 of Versed, and 5 of Haldol right off the bat to try to settle these people down. And Dr. Daly obviously was well involved in that. And then in Gary's case, last month or 2 months ago, it certainly would have been beneficial to our, we're not going to get around all of the protocols. We had maxed out the protocol, limited cell service, there's a lot of obstacles in the territory in which we serve. So, they have to give us better tools, and I think that all of that, was a great discussion, in which will probably lead to Haldol being put back in the formulary.
So the drug at Camp Bisco, the drug of choice at Camp Bisco among the participants was mostly what, bath salts?
Molly?
Molly, it was funny because it worked in waves. Like the first day was ketamine, with strychnine. Oh yeah, their ketamine laced with strychnine. Then the second day it was all mollies. The third day it was heroin. So it was actually waves. We saw these waves coming through. I don't know if it's just the way it worked out, but certainly every single time, once we got the Haldol and the Valium, that made things a whole lot better. It worked 10 times better than Versed alone on these patients.
So these are takedown drugs, right? We're trying to just control them enough to get them out of stretcher.
Correct. And then, out there, obviously, we were directly under physicians. I mean, for all intents and purposes, we were nurses in a field hospital with 2 physicians there just barking orders to us. And I mean, it was not uncommon. We had one patient, I think, 40 of Versed, 10 of Valium, and 5 of Haldol. It was truly, yeah, I mean, it was crazy things. So, and then they'd come out of it. It was a pretty interesting event.
So you got back on a re-enlist for 2014?
I'm not sure that they're having that, and
There's been a lot of side discussion. New York City shut down an event because of the drug deaths and episodes. Why is it allowed upstate and not that, and downstate shuts it down? We're waiting to see what happens.
I think a lot has to do with the promoters on whether or not they're going to allow it to happen. I don't know if I would re-enlist at this point. They would have to give us a lot more money than what they gave us.
So part of the dilemma was the event turned out to be much larger than advertised, right?
Right. They originally, we had planning, it met Part 18 standards. They had advertised 17,000 people, and at one point in time, there was in excess of 40,000 people. And it's not 40,000 people. When I look at what we staff on a normal day to cover, all of the county, it was the same staffing that I guess we cover 52,000 people, and we had basically 2 more people on duty for our regular ambulances. But everybody's drunk and everybody's doing drugs. The plans called for 6 paramedics on scene. At one point in time, we had 23 paramedics on scene and 2 physicians. So it was just a complete, yeah, it was chaos. You couldn't even imagine it. So, and the guidelines were followed. The Part 18 guidelines were followed. They had the plan for that number of people. The problem is it doesn't take into consideration what kind of event it is. If it was a 3-day classical musical festival, hell, we'd have no problem. A 3-day festival with lasers, Molly, and alcohol is a different story.
Tom, who had the contract for that before you guys were?
No one.
Oh, no one. Oh.
Yeah, we got the brunt of that from Lifestyle in Dwaynesburg.
Well, Mohawk had done it the year before that.
Mohawk did it the year before.
They didn't cover. Nobody covered the event.
No, they wouldn't go inside the
Nobody
property.
would cover
The
the
Hawks
event
staged
based
outside
off
the
of
grounds,
18
and
standards.
they were brought out to
Everybody had ambulances, they had an ambulance mobilization plan, basically, and all of the ambulances were outside of that event. So any care that was given was outside of that event. So basically, when we walked into it,
Well, you were the first one that didn't, I mean, in their defense, I can tell you that the promoters in the eyes of the ambulance could not guarantee the safety of the ambulances and the crews. And that was the reason previously that no one wanted to go on the grounds.
Just more moves.
To give a little background, this is a private property billed as a country club. It's not like any country club I've ever been to. But anyway, they do not allow police on the grounds, and the policing is done by the people that attend the Harley Rendezvous, are hired as staff.
Bouncers.
That's the
That's what it
bouncers.
is, that's true.
And that's the Fox.
And that's, 90% of the problem, I think, the liability wasn't for us after doing it. The liability wasn't necessarily the medical care. I would certainly perform or offer to do the medical care again. How the patients got to the medical facility is probably where the liability came in. We didn't know how these patients were selected to get to us, and certainly it was an interesting.
Was there a trauma mix as well?
We only had one trauma patient, and that was just a gentleman that had taken a few too much. They had, of all things, they had one of those big stunt bags, and they had a 35-foot scaffold that you would climb up and jump into this big airbag. And we had one individual just miss the airbag. So that was really. We had one or two people with their foot run over, but the level of trauma was minimal. I think out of all the patients, 99% of all the patients that we treated were overdoses.
All right, well, those are learning. So people learn from these experiences.
But it's interesting to note, though, I mean, he brings up a good point, as does, heroin is on the increase across the board. Well, you're going to be encountering it more and more.
There was one day last week, we had 6 overdoses in the ER at one time.
Yeah.
All heroin.
We've had a whole bunch of them this past week in our
I
here.
say Oneonta is constantly has heroin overdoses.
And they're telling us that heroin is easier to get than marijuana now.
And it's cheaper.
It's cheaper.
Cheaper than pot.
Yeah.
And actually, you're getting a lot more younger people hooked on heroin early.
It's wonderful.
So without
Keep
hound
the
dog,
technicalities.
can we get a protocol for tasers?
Whatever happened to the old days of O2 therapy? You just put a bottle up.
On camera.
We can edit this stuff, right?
I've gotten very good at that.
Good, we'll give you a list. All right, so next up, discussion on when a tech should remain with a BLS student.
This is a fascinating question. We have a certain agency in the region, one of the newly minted critical cares on board that agency, called me up in rather high dudgeon, but that's his modus operandi. He said that he was being criticized by his agency because every call he goes to, he likes to start an EKG on the patient. But when he sees from the EKG and the general clinical presentation of the patient that it's going to be a BLS call, he just leaves. He said, I'm not entirely sure you can do that once you've started ALS care on the patient. Well, he says, that's it entirely. He says, I hook him up to the EKG so I can see whether or not to start ALS care on him. Well, I said, EKG is considered ALS care. So anyway, we talked a little bit about that, and I said, I tell you what, I said, this is a wonderful phrase to mollify people. I said, well, bring it up at the REMAC. Oh, he said, good. So
we're going to kick it to his medical director. Who's the medical director?
Dr. Glenn would be his medical director.
Is he aware of this? Has he actually done that, abandoned?
He's done it more than once and received some criticism from his agency for it, and I think correctly so. Jill can add a little bit to this, I believe.
I just happen to be reviewing some of his PCRs, which are difficult to read, but...
Her agency is not the one in question, by the way.
And I had actually come across what he wasn't doing is he wasn't attaching like the code summary off the monitor or the EKG to his paperwork. He wasn't even mentioning it in his paperwork that he had done anything. However, he did make a mistake and attach an EKG to one of the PCRs, and it was for an ankle pain. And he turned it over to an EMT from another agency. This was a link up that he went on. And I questioned him. I actually thought that the EKG belonged someplace else. And he said, no, he said, I perform an ALS assessment on every single patient. And I didn't know the other agency that he had belonged to had just criticized him on this a couple hours prior. And I said, why do you perform an ALS assessment on every patient? He said, because I'm an ALS provider. I said, no, we perform patient assessments.
Yeah. BLS before, yeah.
You know, and if they don't meet a
Let me take this to
criteria.
executive session. We'll
Yeah, I
have
like
to-
Sure.
Yeah.
Okay.
we can have
It's kind of a fascinating question.
very
Yeah, it's just,
specific.
he's,
one-off case.
Sure.
Some remediation sounds like it's in order there. New business, nothing, Aaron Scott mentioned is participating in the CPAP demonstration project, and they commented there's no data from Aaron's yet. I assume that's because we just kind of got into it.
Yeah, there's nobody practicing.
We've had no uses. We've got 11 squads, no, we've got 12 squads,
Oh.
plus CMT is coming on board with them.
Okay.
So we're pushing it. Everybody, encourage everybody to use it.
So update on, so
Don't give them fire breath
correspondence,
until we're here.
that was it. Old business.
I have,
protocol.
excuse me, I have, guys, I just was handed two small pieces of new business. I have from the Worcester squad, agency letter of intent for participation in the BLS intranasal Narcan program. Dr. Jones has agreed that,
There is no more.
There is no BLS,
Doesn't
more
exist.
BLS intravascular.
Though they haven't passed by REMAC?
It's part of the BLS.
Part of the
there's
BLS
an-
care now.
It's a BLS protocol.
The policy statement said that REMAC had to approve it.
That's correct.
Yes, it does.
The
Right, but
REMAC
it's
still
not
has
a
to approve.
demonstration
Yeah.
project.
I didn't say, does it say demonstration in the?
no, it doesn't say, just says program, right?
Okay.
Yeah, this is the document which states, and Sid Chase is the captain, and Dr. Jones, the medical director, they have signed off that Worcester is ready to go pending approval of the REMAC.
All right, all those in favor? Good. Sounds like we need a lot more Narcan down
Could I please get a verbal approval on that? I will be doing my BLS Narcan training next week and provide the documentation to the region.
Okay,
For CMT.
CMT pending approval,
Thank you.
pending completion.
Is this, what's needs approval, the intranasal part of it? Because you already have Narcan.
Correct. It's just that we haven't
BLS.
paid BLS providers,
BLS.
the BLS providers.
Yes, BLS.
Thank you.
Also, Worcester has completed all their paperwork for the end of the glucometer program, but they do not yet have the CLIA waiver, though it has been applied for. Would the REMAC consider approving them pending receipt of the CLIA waiver? Just to save a little time, because we won't be meeting for 2 months.
All those in favor?
Phil,
Where does that come from?
That comes from the Department of Health Wadsworth Labs, and it's sometimes a little slow in coming. But they've already applied. The big thing is they sent you $200 in. I presume you did anyway.
No, it's free.
It's free now.
It's free.
There are
Congratulations, it's changed.
Volunteer fire department emergency squads are free now.
Really?
Yeah.
This must be an election year. Holy cow.
If you send your money in, you don't get it back.
Oh, is that right?
That's what an agency
Just
told
has
me
to
the
be,
other
it
day.
has to be fire department?
Fire, yeah, it has to be
And
volunteer.
you
fire
have to
department
state
emergency squad.
specifically that you have no paid employees.
Correct.
Yep.
So it can be volunteer ambulance agencies.
Okay,
Correct.
I was not
Yeah,
aware of that.
employees.
I will send that notice out to all our mailing list, so that all the squads realize. that they're going to send
I
money.
can if you want tomorrow, I can send you the actual link to
Oh,
the
okay.
legislation.
All right. Okay, great.
Sir, can we add all my squads on to the intranasal Narcan minutes that you're adding there? Everyone's been trained and everybody already has it,
Okay.
but let's just make sure the paperwork there reflects appropriately there. This REMAC.
You signed, you got your signature in that file?
Absolutely.
Virtual, it's on film, we won't edit that out.
Phil, if we were part of the demonstration, do we have to get clearance again to?
I'm sorry.
It moved away from being a demonstration project.
It's no longer.
Right.
It's got
So we
part
have to
of, it's now
resubmit.
part of the BLS program.
Right, but what she's asking is if their agency participated in the demonstration, already has the training, can they be grandfathered or approved by the REMAC?
kind of makes
You're
sense.
not doing it now. You're talking about Fulton County or Northampton?
Fulton County and Northampton were both.
Are you providing it currently, when you say you completed?
Yeah,
the
my
initial-
BLS boxes have the Narcan and the,
Well, that means, must mean you've already been approved.
we were part of the demonstration.
Right. Yeah.
She's asking
But I'm
if you
asking,
have
do I
to
have to
resubmit.
resubmit the paperwork again?
Oh, but you're
Even though I
approved
was-
already.
What's that?
Why would you have to resubmit it?
I don't think she's being facetious. If she's following the letter of the policy,
Right.
she has to notify the REMAC so that they can be aware of agencies providing, because if I'm not mistaken, Mary can correct me, every time you have a use, you're supposed to provide the documentation to the regional QI for review. So it's really a notification process, so you guys know how much Narcan's getting used out there.
That's what
Yeah.
I'm thinking.
Is that stipulation part of the BLS protocol as well? Like per use, you're supposed to notify?
Yeah, if they're supposed to, yes. it's in
Yeah.
the-
So nothing changed there. So what we could
Hold on a
say
second, Glenn.
is that any agency that participated in the intranasal Narcan demonstration project is forthwith approved to continue under BLS protocol.
This is a little bit like that scene in the MASH show where Radar O'Reilly says to Colonel Blake, would you initial this document and then please initial your initials? So we know that you initialed it. Okay, so we'll do that. Okay.
All right. No new protocol stuff, there's just discussions about agents and
No, nothing, I haven't received anything at all.
agents will probably be held in abeyance until, well, it'll go on during this year, I think, and then in January 2015. We will have protocols.
Okay, so we do have a couple of little items for an executive session.
All right.
They came in after I sent the agenda out.
Any other business for the?
Yeah, just like to make a point, Howard, Beth, and myself have been asked by Dr. Daly to sit on a committee to review these protocols from a provider perspective. So we're all available if anybody had comments or interest. I know you can apply your questions directly to I think the REMO site has a survey, kind of survey monkey thing, but the three of us are also available if you have thoughts, comments, and input.
Yeah, Dr. Daly also mentioned that if you have an iPhone, you can download the protocols.
Yeah, it's pretty slick. It's nice.
The New York State
free
Collaborative
app
Protocols.
with the collaborative protocols.
NYS.
Here.
I'll send you the link, Phil.
Okay.
And you can forward it to.
I think that
There it is. Got it.
Joyce and I may be acquiring a smart device.
Fortunately, it is only for an Apple product.
Tools and the rest.
It does not, they do not have the Android out yet.
Which made
They're working on it.
Any other business for the full REMAC before we have to do this executive?
I don't have
Great
anything.
question
No.
to ask Gus, he might know. Did you know if the SREMS app is the same as the collaborative app, or is it
No, it
changed?
has more medical control telephone numbers in it.
Is that the difference though? That's it?
That's
The protocols
about,
are the
yeah,
same?
the protocols are the
Protocols the
same.
same, okay.
New York State's EMS.
All right,
No,
so
that's just
adjourn
emergency.
this REMAC.
Yeah, I'm
That's
gonna ask a short executive session, and I'll ask the REMAC members to adjourn with me. I think we can go next door. I think this is empty.
I've used it several times.
I think it is. We'll know in a minute.